Good morning, everyone. I'd like to welcome you to this symposium that's been organised at the AIOS meeting by the Royal Australian and New Zealand College of Ophthalmologists. My name's Peter McCluskey. I'm currently the Vice President of RANZCO. It's my pleasure to introduce Dr. Grant Raymond, who's the President of RANZCO, who's going to give the first talk, and it's going to give a bit of an overview of RANZCO and who we are and what we do. Thanks very much, Grant.
Thank you, Peter. It's a pleasure to be here representing RANZCO, which is the Royal Australian and New Zealand College of Ophthalmologists, the peak body for eye surgeons in both Australia and New Zealand. The initial talk I'm going to give before we get on to some more academic subjects is just to give you an overview of RANZCO's reach and plans strategically for the coming 3 years and describe somewhat the relationship that's been very strong, but it continues to evolve with the All India Ophthalmological Society. I have no financial disclaimers, and my thanks goes to Nitin Verma, Kristen Bell and Justin Morrow for all the work they've put into this 2030 and Beyond project, which is the centrepiece of our strategic plan moving forward. There are 6 pillars to Vision 2030 and Beyond: service delivery, workforce and training, Aboriginal and Torres Strait Islander healthcare, and there is a New Zealand version of that too with Maori and Pacifica Care. Global health, eye health, which I'll talk a little bit more at the end when we discuss the relationship with our Indian colleagues, and preventive eye care and sustainability. Why Vision 2030 and Beyond? It's an effort to get some equity into eye care in both Australia and New Zealand, in closing the gap not only for First Nations people but also for those in socio-economically challenged positions and less regional centres. It entails sustainability in both healthcare delivery and workforce. There are in fact 2 plans, one for both Australia and New Zealand, which are independent geographically. In Australia, we have Indigenous communities impacted at 6 times the rate of blindness that the rest of the population is. We have an ageing population with comorbidities, particularly the epidemic of diabetes. Maldistribution of services limits our access. We have long wait lists and under-resourced public ophthalmology, so similar problems to which most countries are trying to do battle. RANZCO has led stakeholder engagement to improve the patient journey. Key priorities are basically development of collaborative care models, and these are prioritised under visual disorders in children, diabetic eye disease, cataract, AMD and glaucoma. These pathways will entail telehealth and telemedicine and cooperation with our optometric colleagues. Working groups have been established and stakeholder engagement has been underway. Our stakeholders are many and varied, as this busy slide illustrates, both from a government level, from patient representative groups and other organisations such as Optometry Australia and Orthoptics Australia. We will continue to advocate for Indigenous eye health and workforce solutions. Closing the gap has proven to be the holy grail in Australia. We've struggled for many years with enormous efforts in terms of money, but little to show in terms of outcome. We're hoping to identify areas for collaboration and partners to solidify these outcomes, with our key resource always being our fellows who provide a workforce pro bono which is dedicated to the equity of eye care. New Zealand has similar problems with an ageing population, increased demand on services, growing wait lists, and a First Nations equivalent in terms of Maori and Pacifica communities that's underserviced and inequitably dealt with. Previously there's been no national eye health plan. The New Zealand plan creates trust and shared decision making, trying for these equitable outcomes which are so hard to get, and a sustainable ongoing process. A key advocacy success in New Zealand, which is in advance of Australia in some respects, is the establishment of a national eye health network with leadership from RANZCO fellows. Priorities here include governance structure, development, a short and long-term plan, suitable data collection to define the problems, service gaps prevention and screening programs, collaborative arrangements, and the ever-present difficulty of workforce issues. Relationships with government are always fraught in that there's a turnover, and with a recent election, new ministers need to be brought into the fold if the plan is to be successful. We have peak body collaboration and joint advocacy activities, including children's vision advocacy, ongoing. We're collaborating with our New Zealand optometric colleagues to try and find the best working models moving forward, and meeting, as I mentioned, with the new government ministers responsible. One significant gain has been the development of a national score so that people qualify for government-funded cataract surgery at a similar level of impairment throughout the country. Immediate priority is workforce, addressing regional shortages, funding for New Zealand training posts, and ongoing efforts to strengthen the Māori and Pacifica health workforce, as we're doing in Australia. I'd just like to finish with a few minutes on global eye health, where RANZCO is very active, particularly promoting support for South Pacific Island nations, and this is an area of cooperation with the All India Ophthalmological Society. Pacific is an area which is underserved and inequitably served, with significant rates of blindness and visual impairment. 90% of this vision is avoidable or treatable, and it's the same culprits: cataracts, uncorrected refractive error, and diabetic retinopathy. The prevalence of vision loss will markedly increase over time, and we have rapidly growing and ageing populations, and another issue with diabetes control as well. Urbanisation and the climate crisis will add to the dilemmas. Government should recognise the burden from diabetes, include eye care and human relation plans, integrate eye health in national plans. It doesn't seem to come as a priority, and invest in data collection. RANZCO's focus will be this region moving forward with our overseas commitments and aid, with an emphasis on supporting PAC Eyes, the local providers in the region, coming up with a plan that incorporates hubs for surgical teams and ongoing education and training. We're supporting advocacy in the lead up to the CHOGM, which will be in Samoa later this year, trying to engage governments at all levels and strengthening our collaborations, as previously mentioned, with the AIOS, American Academy, APAO, IAPB, and other not-for-profits. We're promoting fellowships and observerships, and I would flag to you the Global Eye Health Workshop in Adelaide at the end of October this year, and we'd love to see anyone from India there who's interested in this area. RANZCO extends that standing invitation to all stakeholders to contribute to the plan, and we look forward to strengthening an ongoing relationship with AIOS in the future. Thank you very much.
Thanks, Grant. My pleasure to introduce our next speaker, who's Dr. Peter Haddon from Auckland. Okay, so Peter's got a different title to what's in the program, but we'll look forward to hearing what he has to say. Thanks very much, Peter.
Hi, I'm Peter Haddon. Yeah, it's a different title there, but I was told to give this, on my email, the same talk as I gave previously, so I apologise if there's any confusion, and apologise if anyone has heard this before. Not sure how that happened. But anyway, I'll talk about multimodal imaging, which of course is the use of one technology to acquire images, more than one technology to acquire images that complement each other. Let's look at photography first. So photography has many uses, one of which is remote diagnosis, for instance in diabetic screening. I also run a virtual multimodal imaging tumour clinic in which I review the images of patients without seeing them to rule out benign lesions such as this nevus, which you can see has no autofluorescence on the fundus autofluorescence, and is relatively dark on, no fluid on OCT, and is relatively dark on autofluorescence. And as Grant has mentioned, we have an interest in diabetic photo screening, and we're cooperating with the All India Ophthalmic Society in this regard, and came out with that statement last year after the meeting in Kochi. Of course, photography's changed in recent years, and we now have wide field cameras that have much improved our ability to visualize the periphery and large lesions such as this choroidal melanoma. You can then put different filters on your camera. Adding a red filter can image choroidal lesions better, while red-free photography can highlight red lesions such as hemorrhages and diabetic retinopathy. Many modern cameras, of course, also do fundus autofluorescence, which detects lipofuscin and other fluorophores, and you can also use it to see subretinal fluid, which is visible just next to the optic nerve here in the OCT, but also shows up on the autofluorescence. There are diseases that affect the RPE, such as serpiginous choroiditis, can also be quite easily followed with fundus autofluorescence. And congenital hypertrophy of the retinal pigment epithelium shows up as a very dark lesion on autofluorescence, and on OCT you can see atrophy of the retina and choroid with some increased signal from the RPE. Photography also allows sharing of problem cases. So in the South Pacific, we have a WhatsApp group that doctors from small Pacific Island countries can use to get advice from colleagues in Australia and New Zealand. Also, of course, if we have problems of our own, we can ask other people what they think of things, and vice versa. Serophotography can sometimes even make the diagnosis, such as in this case of uveal melanoma. And of course there's also fluorescein angiography, which I'm sure everyone knows about. So OCT. So I guess in the retina you use OCT in two main ways. One, using a map of a wide area to show, say, generalized thinning from this branch retinal vein occlusion, or you can do it slice by slice to look for very localized pathologies. Some people suggest that using black and white images make it easier to visualize pathology. I'm not really convinced by that. And of course you can use enhanced depth imaging when you do an OCT to visualize the choroid better. And here you can see that you can actually see the over a millimeter thick choroidal melanoma. Many machines, of course, now support OCT angiography, allowing non-invasive visualization of the circulation, such in this case of diabetic retinopathy with some edema and also a bit of ischemia. And we still, of course, use ultrasound, very useful in tumours where you can measure the tumour, you can look for response to treatment, and characterize it by its echogenicity and shape. And of course, it's also useful for imaging the posterior segment if you've got media opacity. So I'll show a few examples Here is a typical choroidal melanoma. So here you can see the classic suspicious features of thickness greater than 2 millimeters, subretinal fluid on the OCT, lipofuscin lighting up on the autofluorescence, and on the ultrasound you can see it's hypoechogenic. Some melanomas can be associated with an inferior serous retinal detachment, which shows up very easily on fundus autofluorescence. And this is an unusual one with a cyst on both ultrasound and OCT. Here's another pigmented tumor. It's a little bit unusual clinically because it's got that exudate around it. But on autofluorescence, you can see that it looks very different from the melanoma I showed before. It's very dark. You can't see any hyperautofluorescence on the tumor itself, which you'd normally see with a melanoma because of lipofuscin. And then when you do the OCT enhanced depth image, it's obviously not necessarily choroidal. Finally, when you do ultrasound, you can see it's also not hypoechoic. In fact, it's somewhat hyperechoic. So this is classic of adenocarcinoma of the RPE. And luckily, in this particular patient, a few years later, we got histology on this eye for other reasons and confirmed that diagnosis. Another lump in the peripheral retina. So when we OCT through this one, we can see a large pigment epithelial detachment. And this makes you think not a tumor, but peripheral exudative hemorrhagic chorioretinopathy. And then you can confirm that on both OCT and photography because you can see that it's starting to go down 3 months later. This is a patient with Sjogren-Larsen syndrome. On fundus photography, all you can really see is probably a few little crystalline deposits. Maybe the foveal reflex doesn't look quite normal. And you can see these crystalline deposits on OCT. But then when you do fundus autofluorescence, you can see there's some more general pathology. A white tumor this time, again in the choroid, again with subretinal fluid on OCT. But then when you do an ultrasound, you can see it's very hyperechoic with acoustic shadowing behind it, typical of an osteoma. Another tumor. This tumors are rather hard to see on the color photos because it's almost the same color as the fundus. Although you can see a large amount of serous leakage and serous retinal detachment inferiorly on fundus autofluorescence. Then when you do almost finished. When you do the ultrasound though, you can see it's very hyperechoic, and this of course is typical of choroidal hemangioma. So, thank you from New Zealand.
It's now my pleasure to introduce Nitin Verma, the immediate past president of RANZCO and our head of global health, who's going to talk today on management of dry AMD, new horizons, new strategies. Thanks, Nitin.
Thank you, Grant. And I know how many of you deal with AMD in this room? I mean, a few of us, but all right. Now let's talk about the new elephant in the room, which is dry AMD. Yeah. So really but practically there's no treatment for GA. And, there are a lot of things in late clinical trials, but the point is that the treatment is coming, and some treatments have already been approved in the United States. And those of us who are going to be managing GA need to be prepared to manage GA. And it's going to change things for the patient, for you, for your practice. I think the time to start thinking about it is now. Geographic atrophy is a clinical diagnosis made on one simple photograph. A color photograph where you can see a pale area, you can see the choroidal vessels underneath, sharp demarcation, and it can usually starts perifoveally and then moves and involves the fovea. So in the beginning, the visual acuity is fine, but patients complaining about not being able to read and missing out things, but sometimes it can start under the fovea. The main thing is to differentiate it from inherited retinal disease, because the treatment for both are quite different. So I think sometimes if you've got drusen, then you're more likely to be looking at GA rather than IRD. Fundus autofluorescence is suddenly becoming very important in this domain, because you can mark out and map out the GA quite clearly. And it's also important in being able to look at the progression of GA, and if you're involved in a clinical trial, for sure they're going to ask you to do a fluorescein, an autofluorescence rather than a fluorescein angiography. There are different patterns of autofluorescence. It could be focal, it could be banded, there could be diffuse trickling, and the diffuse trickling one is the one that's associated with rapid progression of the GA. And in all clinical studies so far, the primary outcome is the rate of growth of the GA. So, it's all dependent on autofluorescence. So while AMD is multifactorial, and there's the physiology and lifestyle and environment, I think, and the genes, but I think what's becoming more and more important is that inflammation seems to play a role in this thing. And then complement comes into the equation. There are key lines of evidence for genetics, CFH, CFI, C3, C9, but that's not all. There are many pathways implicated in the pathophysiology of GA, and so there are as many current treatment approaches. But today we're just going to talk about the inflammation and complement inhibition. So that sort of gives you a snapshot of the pipeline, including the drugs that have failed. One that's still early in the development is to sort of suppress complement factor B. The advantage here is it can be given by subcutaneous injection. Again, it's in development. Gene therapy has the potential for a one-off treatment. Gene therapy in Australia, in Melbourne, started in 2021. And then there's also, the other early inhibition of complement. But really, what we've got in hand and what's around the corner is to do with C3 and C5, which accumulate in drusen and the sub-RP space in AMD. So I'm going to talk about the C3 and then C5 inhibition studies. The C3 inhibition is using PCP. It's a complement inhibitor, and it binds, doesn't matter what the pathway is, but it binds to the complement pathway, blocks it, and hopefully prevents cell death. The OAKS and DERBY trial use PCP. Large study, 4 groups, PCP every month, every second month, and then 2 sham arms, again dependent on autofluorescence. But the main thing to remember is that the drug that you inject is quite oily, and that it is a 0.1 mil injection. And again, looking at the growth rate, in the OAK study, the primary endpoint was reached where it slowed the growth down. In the DERBY study, at the end of 1 year, it wasn't reached. But when you went on to 2 years, you can see that continuous treatment helped to slow down the rate of growth of GA. And you can see that here on this autofluorescence, how you look at the reduction in growth by actually calculating. Now, GA normally grows at about 100 or 150 microns a year. And then if you can slow the growth down, you can also calculate the square millimeters of retina preserved. And so it gives you an idea how you can quantify what you're doing. The good thing is that the better result between foveal and subfoveal is in the non-foveal region, in the non-foveal patches of GA, which is good because then you can prevent the fovea from getting involved and perhaps preserve the vision. So as you combine, you look at non-subfoveal, which is on the left, and subfoveal, you can see that the effect is greater in non-subfoveal regions. They've gone to the extent of also calculating the number of RP cells saved, but unfortunately, in terms of the visual function endpoints, they were not achieved. You wouldn't expect that if the fovea is involved, but what one could do is microperimetry in the junctional zone to see whether that makes a difference. So that's 250 microns around the lesion, and you can see that it did have a positive effect on the mean sensitivity and the number of scotomatous points when you use an investigation like microperimetry. Let's go on to the third year, the GALE study, which is the extension, and you find that the gap between the treatment and the sham arms keeps on increasing, which means the result of the drug is such that you continue to get some positive effect. After 2 years, when the sham arm was put on treatment, again, the response can be seen in that green line there. Again, AI to the rescue, you can see, we know that photoreceptors are lost before RPE, and that's shown here using AI again and the OCT, where you can see that the loss of photoreceptors is earlier and faster than that of the retinal pigment epithelium, and this drug then actually protects photoreceptor and RPE loss, as you can see here. So this might be another tool that one can use in addition to microperimetry for future studies. The adverse events over 24 months, none really significant, but as we go on, one thing that did become apparent that in this group there was an increased prevalence of or incidence of neovascular AMD, and usually occurs at the edge of the GA and the normal tissue. It's occult and it responds quite well to treatment with our standard anti-VEGF agents, and monthly injections give you a greater chance of developing neovascular AMD in this group. So safety-wise, there didn't seem to be anything unusual, but one's got to be cognizant of the fact that AMD does develop. So the other trial that is again, perhaps even more spectacular than this is C5 inhibition using ACP. I always find it difficult to pronounce all these molecules, so we just call it ACP2. But the GATHER study shows that there's a 56% reduction in geographic atrophy at 12 months. So these two drugs are around the corner. They're available in the US, and I hope that next year or even this year, we'd have access to them in Australia. But the take-home message is really that our thinking needs to change. We can't treat dry or we can't treat GA the same way as we treat neovascular AMD. We need to prepare for treatment of GA. We need to educate the patient. We need to start thinking differently in terms of trying to preserve retinal tissue, in terms of trying to preserve or slow down visual loss. So we need to also be able to confidently diagnose GA and make sure that we don't get stuck in things that look like GA, because then that would be a disaster. So they're around the corner. It's another group of patients whom we should be able to help, but you need to start thinking about that right now. Thank you.
It's now my pleasure to introduce RANZCO Vice President Peter McCluskey, who's a leader in uveitis and teaching. Peter, thank you.
Great. Thanks very much, Grant. Thanks very much for being here. So what I really want to do is take you on a little bit of a journey that shows you, my slides aren't working, that takes you on a little bit of a journey as to what we've learned in uveitis over the past few years and how it's sort of come into the 21st century. And there's hopefully 5 things that I'll be able to cover over the next 10 or 15 minutes. It's not advanced. Thank you. So the first thing I want to talk about is the Sun collaboration. And essentially, as you can see here on the slide, the Sun collaboration basically ended up with classification criteria for 25 common phenotypes of uveitis that we all looked after. It's basically a 17-year journey, this study. I went to the first meeting in 2004, and we had our last investigators meeting in 2019, and those 25 classification criteria were all published in the same issue of the American Journal of Ophthalmology in 2021. And essentially what we've now got is a language that allows us to talk around in a consensus manner to our colleagues around the world. We've got an agreed anatomical classification, descriptors for uveitis, severity grades. We've defined a meaningful change in vision. And what this means is that although these diseases have classification criteria that we use for clinical trials. They're really de facto diagnostic criteria for all of us to use in routine clinical practice. And this will lead to much better communication between each other. It will allow us to combine data from multiple clinical studies. I'm sure it's going to improve our understanding of the epidemiology and outcomes of different phenotypes of uveitis, and it will finally allow us to design multi-centre disease-specific clinical trials. I'm just struggling to make this, okay. So I want to talk now about a couple of the really important clinical trials that have happened over the past 5 to 10 years. The first one is the MUST study, the multi-centre uveitis steroid treatment trial, which ran over 7 years and essentially randomised patients to either systemic immunosuppressive therapy or RANZCO, which are intravitreal dexamethasone implants that last for 3 years. And the patients were then very carefully followed up for 7 years. And essentially the results of this study are that although both are very effective, systemic treatment gives you better visual outcomes over 7 years. The other important points are that 62% of the group of patients treated systemically needed some form of local or regional therapy at least once over that 7 years. Both arms of treatment controlled the macular edema in more than 90% of the patients, but in each arm, close to 50% had a relapse at some stage. Cataract surgery was quite safe in this group of patients and had good visual outcomes. And not surprisingly, 40% of the patients who had steroid implants developed glaucoma, whereas it was much lower at 8% in those on systemic therapy. So a really important landmark clinical study in uveitis. The next study was the FAST study, which compared the two common steroid-sparing drugs that we use in clinical practice. And again, an international multi-centre randomised controlled clinical trial where patients were randomised to a maximum dose of either methotrexate or mycophenolate and then followed up for a year to see what happened. The bottom line is that there's no difference in efficacy between the two drugs, and there's really no significant difference in the side effect profile. And this is really important because methotrexate is a far, far cheaper drug than mycophenolate, and it's just as effective, and it's become really our first-line steroid-sparing drug. The next important study was the MERIT trial, which looked at different local treatments that we use intravitreally to treat cystoid macular edema in patients with uveitis. And so the drugs were an Ozurdex, an intravitreal dexamethasone steroid implant, an anti-VEGF, in this case ranibizumab or Lucentis, an intravitreal methotrexate, which many of us have used as salvage therapy in patients with non-responsive cystoid macular edema. And the outcome is basically that the steroids work and the other two agents don't. Methotrexate really had minimal effect and had a significant higher rate of 15-letter vision loss over the time course of the study due to persistent macular edema. Dexamethasone or RANZCO were by far the best drug in terms of efficacy, and not surprisingly there was a modest number of patients who developed mild rises in intraocular pressure. The next important study in this journey was the POINT study, where we looked to compare periocular with intravitreal corticosteroids to see which worked the best. So the arms of the study were periocular triamcinolone, intravitreal triamcinolone or Triesence, and again intravitreal dexamethasone implants or Ozurdex. And essentially the endpoint was to see what happened to the macular edema at 8 weeks' time, and the patients were followed for 6 months. So the important outcomes were that all drugs work at 8 weeks, but intravitreal therapy is clearly better in terms of controlling macular edema and improving vision than periocular steroids. In this trial, the orbital floor steroid patients were crossed over to intravitreal steroid therapy at 8 weeks. There was really no difference between the number of patients who developed raised ocular pressure between periocular and intravitreal steroids. So if you want to control cystoid macular edema and you need local therapy, the most potent therapy is intravitreal therapy. It may not be the most appropriate choice in a phakic patient, but it's the most powerful therapy. So I've fairly quickly run through most of the important pivotal sort of uveitis clinical trials. There's two I haven't mentioned. One was the Sycamore study, which looked at adalimumab Humira therapy in children with JIA and showed that this was by far the superior treatment for those children. I haven't spoken about the visual studies, which were the sort of primary efficacy studies for Humira for adalimumab and showed that it was a safe and effective therapy. The other important study that I haven't had time to talk about are the SIGHT studies, which are huge retrospective case series of more than 20,000 patients with uveitis followed for up to 20 years. The most important outcome from this study, and the primary reason for doing it, was to see whether systemic immunosuppressive therapy caused malignancy and cancer, which it does in so many other diseases where we use immunosuppression. And the important thing is there is no increased mortality from lethal malignancies in patients who use systemic immunosuppressive therapy for uveitis. You do get non-lethal malignancies, you get cervical cancer and non-melanopic skin cancers, but these are obviously readily treatable. For us as ophthalmologists, probably the most important message is that in the long term, for patients with chronic uveitis, 50% of our patients are going to develop glaucoma. And that's when I was a fellow, my sort of mentor always said that the final battle in our patients with uveitis was dealing with the glaucoma. And this clinical trial or this clinical study confirms that. These clinical trials that have been done, and now that we've got the SUN study and the SUN criteria to work with, there's now a whole raft of really important clinical studies that are underway that are going to further define how we look after our patients and which combinations of medications are the best. So the next thing I want to briefly touch on are registries and collection of data. And there's an increasing number of uveitis registries and data banks out there. And the one that I'm involved in is one called this group of registries called the Save Sight Registries from the university where I work. And we've recently launched a uveitis database outcomes registry called Fight Uveitis Blindness. And just to show you the power of these outcomes registries, we only started collecting data 4 months ago, and we concentrated for a particular reason on getting as much data as we could on patients treated with adalimumab or Humira. And across Australia, we got 261 eyes of 141 patients who'd been treated with adalimumab. And as you can see, it's the usual sort of collection of diseases that cause vision-threatening severe uveitis, mostly posterior segment disease. And these diseases, or these phenotypes of uveitis rather, have always been very difficult to treat, particularly, for example, a disease like birdshot choroidopathy, where 20 years ago, the vast majority of patients with this disease went blind, as did the majority of patients with Behçet's disease. So when you treat these patients with adalimumab, this is just a 2 or 3 slide summary of a large amount of data. The important take-home message is that there's this really powerful, prolonged, sustained steroid-sparing effect. And as you can see in these 261 eyes, 2/3 of them, 66%, were able to stop all systemic steroid therapy, and 87% of them were down to a safe dose, either 0 or less than 7.5 milligrams per day. And that's something we've never been able to achieve with other medications. Very importantly, these patients, this treatment stabilized the vision in our patients. It controlled the uveitis, it got rid of the macular edema, and essentially in the vast majority of our patients, 87% of them, visual acuity, it was either stabilised at its current level or improved, and only a relatively small number of patients lost vision, and this was usually fairly mild visual loss. So the message here is the sooner you can get your patient on to a drug like Humira that works, the better the visual outcome is going to be. So this is just one example of the powerful data sets that an outcomes registry can generate. Obviously this one's in uveitis, but our group of registries has got registries for diabetes, macular degeneration, retinal vascular disease, glaucoma, a whole range of different registries. But the uveitis one, I think, shows you that real-world data is really important in supporting the sort of somewhat artificial randomised clinical trials that we do. It gives us good, useful, ongoing data as to what's going to happen to our patients in the future. And in this particular case, it showed a powerful steroid-sparing effect. It allows us to reduce treatment and gives us really good visual outcomes. And that really leads on to the last two things I very briefly want to finish with. One is that to manage our patients with severe uveitis and vision-threatening uveitis, we need to do this in a multidisciplinary team, in a multidisciplinary clinic. In my uveitis unit, we have a rheumatologist who comes to our clinic every week. We have our own sort of personal on-call infectious diseases physician that we can tap into whenever we need to. And by seeing our patients in the one place together or sequentially, we can get much better visual outcomes, clear communication, make sure that the patient understands what needs to happen, and ensure that we look after the patient holistically and get the best visual outcomes. So that then allows us to use, shall we say, aggressive immunosuppressive therapy to control the uveitis. And for the majority of our patients now, that's systemic therapy, which we use obviously in people with bilateral disease and people with severe unilateral disease when there's an inflammatory mediated threat to vision. You obviously need to exclude infection, but it's important to note that some infective forms of severe uveitis, such as herpetic retinitis, syphilitic uveitis, and toxoplasmosis, need immunosuppressive therapy as well. And the common inflammatory mediated threats to vision that we tend to treat cystoid macular edema, occlusive retinal vasculitis, and multifocal choroiditis. And in the light of the clinical trials and the recent data on Humira, what we do now in my unit in Sydney is that we'll start the patient on systemic steroids, add in methotrexate, usually, occasionally mycophenolate, and then try and taper the steroids. The patient will either go into remission, or if they relapse, we will now go straight to escalating the treatment to a biologic such as adalimumab. If there's further relapses, the MUST study tells us that's not uncommon, and we can usually control them with local therapy. There's going to be a study we've been investigators in called the ADVISE trial is working out whether this paradigm is actually the correct one and a safe paradigm for our patients, and we should have the answer in about 12 months from now. We still need to use regional steroids, as I said. Often we use them to supplement treatment in patients who are on systemic immunotherapy, but sometimes patients with, say, steroid psychosis, we use local therapy in both eyes. And it's really very useful sort of periocular and intravitreal steroids. But you have to be sure that there's no infective, that it's not an infective uveitis. So to finish up, the Sun classification criteria have moved us into the 21st century. We've now got a growing number of clinical trials that have provided important evidence to guide our therapy. We now know that systemic immunosuppressive therapy is safe and effective for our patients. We've got registries that will allow us to modify our therapy and benchmark our outcomes, and multidisciplinary clinics will help to ensure that we give our patients the best chance of a good visual outcome with minimal side effects. So don't be afraid to recommend and use systemic immunosuppressive therapy. Thanks for your attention.
Thank you, Peter. It now gives me a great pleasure to introduce an honorary New Zealander, Dr. Kumar. He's currently working in Bengaluru as an ophthalmic geneticist, but he did spend some years working in Dunedin in New Zealand and has also worked at the NIH in the United States.
Good afternoon, and thank you for the introduction, Chair. And I'd like to thank at the outset the organizers of the All India Ophthalmic Society. With that, I start my talk. As introduced, I have worked in New Zealand. I'll show you an interesting photograph subsequently. I'll talk on clinical translation of ophthalmic genomic knowledge, and I have a couple of affiliation. I'll come to that at the end of my talk. So most people in Australia and New Zealand will recognize this photograph, and this is a traffic jam that you see in New Zealand most often, particularly where I lived in Dunedin in southern part of New Zealand. So you have hundreds of sheep that come against you when you try to maneuver yourself in the traffic. So in Dunedin, when I was working under Dr. Michael Denton, we actually identified about half a dozen retinal genes that causes degeneration, including RPE65. And this is my family with whom I stayed in Dunedin for about at least 5 or 6 years. Now, when you actually take the genomic knowledge and try to apply it to your patients, there are 4 ways by which you can help them, okay? Particularly when you do a genetic test. So they come for you for genetic counseling, and where they at times need a clinical diagnosis where you might have missed a syndrome. And secondly, when you know the mutation, whether it is autosomal recessive or X-linked recessive, you know that the course of the disease will be very severe. So therefore, doing a genetic test helps a lot. The second situation in which they come to you is for premarital genetic counseling. So they have a family history, or they might be affected and therefore want to get married and want to see the options. Then the third category is preconceptional or prenatal genetic counseling. Again, the family history, they already have a child with the problem and they want to plan the next one. And the fourth, which is of interest in the last decade or so in India, is that there are a lot of interventions and research that is happening in the treatment aspect and management, which we did hear in some of the talks earlier in the session, including uveitis. So molecular therapy is coming in a big way. So let me go through 4 different situations that I mentioned, and I'll take few cases and then present how we applied genomic knowledge. First will be the clinical diagnosis. A patient came with suspected senior loken syndrome. And he had basically renal-related problems and renal failure, underwent renal transplantation at 11 years of age, and subsequently, once again, second renal transplant when he was 23 years old. He had a brother who died with renal disease, okay, and then he started to develop ocular problems, night blindness and so on, at a later age. So the physician referred the patient suspecting it might be senior loken syndrome when he was 31 years old. So that's the pedigree, and one of his sister passed away with renal failure. The other brother is all right. The third is himself, who's the patient who came to us. So doing a pre-test counseling, we did a genetic test in the patient, and then we found that there was a mutation which causes, as you can see here, I'll keep my talk as lay as possible, a gene called TTC21B, which causes nephronophthisis 12, which is an autosomal recessive condition. So that was the mutation. There were 2 exons, so it was a compound heterozygote mutation, and both were pathogenic, and that's the reason he got it at a very early age. But there was a problem with the diagnosis. It was not senior loken, it was nephronophthisis 12. So that's the benefit you get when you do a genetic test, when you do a genetic test in these patients. The diagnosis can become much more accurate and molecular in nature. So nephronophthisis is a condition which is a ciliopathy. It affects literally every part of the body that which has cilia, including the eye, and therefore they get retinitis pigmentosa and they gradually lose vision. So we counsel the patient about all this, and the marital options were also discussed with the individual. Now the second situation is where you actually have a premarital genetic counseling. A patient came with Usher syndrome, that's a pedigree, and for many over here, consanguinity is a bit common in southern India, and you can see that these double lines where people get married with first cousins or uncle-niece marriage, that is sort of reducing in the current situation. So in this family, the first girl had Usher syndrome, and they were a twin who were not affected, and she was a graduate at that point of time, somewhere in the middle of 20s as far as her age is concerned, and therefore wanted to know whether her children will be affected. And that is the main thing on which she wanted to decide whether to get married or not. So with the pedigree in Usher syndrome, where they have vision problem as well as hearing, you can quite confidently say that it won't be recurring again provided she marries somebody outside the family, because it is an autosomal recessive condition. But nevertheless, being a graduate and with vision and hearing problems, she put her foot down and said that I want a genetic test to be done, and therefore to be very confirmatory. And we did the genetic test, and it's a gene called as GP9, and we found a pathogenic mutation in USH type 2C. So therefore we said, look, this is a homozygous condition, and therefore both the alleles came from one of her parent because they were consanguineous, and therefore it resulted in this. As far as you get married outside the family, nobody in your next generation will be affected. That gave her a confidence, and she left our counseling session. I don't know after which she got married or not, okay? Right, so that's the benefit with which we apply it in India, where people who reach around 20s and 30s, the parents are very keen to get them arranged for a marriage. The third situation was preconceptional and prenatal put together. The patient was a long-term patient of mine, and he came to me at a very young age, and I've been following him up until 37 years old when he decided to get married. And we did, of course, I'm not an ophthalmologist, so you can all understand the fundus image better than me. So that's the pedigree, and he got married to somebody in North India. He's from South India. There's a reason why I'm saying that. And they wanted to plan for the family, okay, so for the child. So we screened the proband, and he had an ABCA4 compound heterozygote pathogenic mutation, okay. I'm not describing the mutation because that would be too much for this audience. So it was very clear that these two variants, DNA variants, were causing the disease in the individual, and therefore we said that if you marry somebody outside the family, you will not get the disease in the next generation. Accordingly, he married somebody from northern India, he being from southern India. And we had to screen her, and to our surprise, we found that she had a likely pathogenic mutation, which was quite a surprise and learning curve for us. And therefore, it was a very difficult situation, okay. If you go by the pedigree, you would straight away say that you go ahead with the marriage and plan for the next child because it is autosomal recessive, and your wife is far away from your place, and she's in no way connected by caste or community with you. But then when it's a very large gene, and therefore she had a likely pathogenic. Now the situation was, which we explained to the family, is that any one of these alleles from the father, if the child inherits, it's pathogenic. And in the mother, she had one allele, which is wild type normal, and then the other one was likely pathogenic allele. So the more important is which allele the fetus picks. If the fetus picks the likely pathogenic allele, the child will be affected. whereas if it picks the wild type, it won't be affected. So we were equally tensed about this outcome as the parents were. So at 15 weeks, we did a prenatal test. Okay, all these studies are ethically approved by our IRB. And when we tested, this is what happened. The fetus was quite smart. It picked one pathogenic allele from the father and the wild type normal allele from the mother. And therefore, and 15 weeks, we could tell that this fetus, after it's born, will not get Stargardt disease. So that's the power and accuracy of doing a genetic test and helping your patients with the genomic knowledge that we have gained in the past 30 years. Now, let me come to the last situation where people are more interested. We have more patients coming in this group, finding out information about therapy by interventions and research. There are about more than 3 dozen genes, retinal degeneration genes, which are under therapy now. RP65 gene has come into practice, but it's a bomb as far as the expense is concerned. But hopefully these things will become cheaper by the day. So I'm going to talk about one patient who had Usher syndrome, okay, another patient who had retinitis pigmentosa, but did not actually have hearing issue. Okay, this is not uncommon in Usher syndrome. So I'm saying Usher syndrome because of the reason that we screened his genes. Of course, these are other findings of his as well as his daughter. So that's a pedigree, and there were 3 alleles in the family, and some of them were a variant of unknown significance. Is the biggest headache that we have in genetic counseling. And we presume that 2 of these alleles are causing the disease. So the father and the daughter have the problem, so they are very keen about therapy. And the reason is that there are about more than a dozen genes causing Usher syndrome. And therefore, doing a genetic screening is quite complicated, and not coming across VUS is something you have to be lucky with in genetic counseling. So Usher syndrome gene is sort of a ciliary gene which has a pathological effect on the photoreceptor as well as the organ of corti in the ear. Now, there are many therapies coming, okay, like gene therapy, and then you have cell therapy, the stem cell therapy, and then RNA interventions. So RNA editing more than gene editing is picking up more faster, and therefore we do tell all this information. Hopefully, in less than a decade, we'll have all these therapies in practice in retinal degenerative conditions. So the future is, as you can see in the slide, that in a conventional way, a patient comes with congenital cataract to your clinic, pediatric clinic, after birth, and then you do all necessary interventions. But then over a period of time, you see if it is dystrophic or so, and finally you make a diagnosis. It's 3 years because all the signs, symptoms slowly start to appear, and then you know it's a syndrome. Whereas today we do gene screening, and we know what is the gene, and then we can know the mutation, and then slowly as a clinician you start to observe the signs and symptoms, and you can prepare the family for rehabilitation and so on, depending on what kind of syndrome it is. Okay, so that's the way it is going, and you can do all this today in India, every major city. It's slightly expensive to do this test. The test by itself costs about 10,000 rupees. The different kind of genetic test, exome sequencing is the most common that we do for our patients. So therefore, there are 4 situations, as I told: clinical diagnosis, premarital genetic counseling, preconceptional, prenatal, and interventional research reasons for which all your patients come. So if your patients are coming to your clinic, please remember that there are many things that you can do to help them, okay? Not even though there's no currently good treatment available. So that's the summary of my talk. I spoke about a couple of situations, okay? I gave you some of the good situations, but there were bad situations where the fetus did pick up the wrong allele, okay? I didn't show them all, so it's not fairy tale all the time, okay? So with that, this is the Bangalore group I'm associated with, Naren Netralia, and you can see that this is a clinicians group, and then this is the laboratory personnel group in Bangalore, a very vibrant group publishing and doing clinical services in Bangalore with 4 different centers in that major city. And of course, I am connected with other institutions as well, and this is the one in Chennai. And then I have 3 ophthalmologists doing PhD, and Pratibha is sitting here in this audience. And there are a few MSc students who are doing PhD with Maastricht University in Netherlands, okay, as outreach program. And Rajeshwari is doing her, going to register herself for PhD. With that, I come to the end of my talk. Thank you.
Thank you very much. My thanks to the All India Ophthalmological Society for their invitation to RANZCO to take part in this very successful Congress, and we do hope that we will see some of you in Australia in the near future. Thank you again for the opportunity to present, and enjoy the rest of your day.